So the voice is clear now? So the voice is clear now?
Hello everybody. I'm going to move forward with my presentation right now. First of all, I want to take the opportunity to thank Itis Medical Company, all their team for their efforts to make this happen and make this possible during this exceptional period the world is passing through. It's such a great initiative, and I hope it will be beneficial to everybody who is interested in the dental practice. This lecture is about an anatomical feature which is present in mandibular permanent molars called the Radix Entomolaris. But first, I want to take a few minutes to speak about something very, very important, which is a cause that we are here making online lectures and online webinar, which is a COVID-19 pandemic. This is important because endodontists are in the front lines dealing with many emergencies during this period of time. Patients cannot wait to withstand pain, swellings, and a lot of emergencies. So we are in the front lines as endodontists to deal with such emergencies during the quarantine. So a couple of days ago, I have got this image from Twitter, and it describes an important thing regarding our protection during endodontic emergencies, which is what type of aerosols are present when we are dealing with patients in close contact with the patients. So we have two types of aerosols, small and large. The aerosols, the small aerosols are moving with a velocity of 10 to 50 meters per second. This means that it can extend to the operator and to the surroundings to a distance of 1.5 or 2 meters, maybe more. And the large spray droplets, which are generated during our access cavity preparation and rebound to us during operation, are the large spray droplets. These large spray droplets can hit you like a bullet up to a distance of 6 meters. So we have to take some precautions during endodontic emergencies, and this is a funny picture of me during dealing with my daily emergencies in the clinic. So you should have all these precautions or precautionary measures like overheads, face shields, surgical masks, surgical gowns, high volume suction, and saliva ejectors. Do not use just one suction method. You should have saliva ejectors in one part, and the other part you have to have a high volume suction in order to minimize the spray aerosols generated during the treatment. Don't forget your overshoes or surgical footwear. Also, regarding the endodontics, we should operate under complete rubber dam isolation. This will minimize a lot of the transmission of any infectious agent, and operate under magnification. This will keep you at distance from the patient. Please use these during your treatments, especially in this period of time. Also, instruct your front desk personnel to limit the presence in the waiting area to maximum of one patient. And as you can see from this short video, that we can use masks to limit the transmission of aerosols. Any mask, not necessarily an N95, you can just limit the aerosols, and please instruct your patients in the waiting area and your personnel to cover your face while coughing or sneezing. This is very important so that we minimize the transmission of any infectious agents. This is Ahmed Shawqi. I'm a lecturer in Endodontics Faculty of Dentistry, Cairo University. I'm an opinion leader in Dent Supply Serona, certified speaker for Simon microscopy, and my academic field of research is regenerative endodontics. My practice is limited totally to endodontics. As I said before, we are going to talk about an anatomical variation in mandibular permanent molars called the Radix Entomolaris. And to know what we are going through this webinar is to provide scientific evidence about the prevalence or incidence of Radix Entomolaris, provide diagnostic protocols for detection of Radix Entomolaris, provide evidence-based statements about the use of CBCT in diagnosis of such anatomical variation, And we will discuss at the end of this webinar a full clinical approach for management of a case with Radix Entomolaris. I have to highlight that this is a variation of anatomy, and if we didn't know how to diagnose and manage it, it will directly lead to treatment failure. And that's what we don't want to happen in our practice. So I will take the presentation forward, and I will try to make it short and to the point so that we have the maximum benefit and we do not waste much of your time. So the Radix Entomolaris was first described by Carabelli in 1844. It is a supernumerary root located distolingually in mandibular molar. We must talk about the prevalence, which means an incidence, how frequent this anatomical variation can happen. And I recommend this wonderful, amazing book called The Root Canal Anatomy in Permanent Dentition by Marco Verziani to read whenever you want to know anything about the incidence and management of anatomy. The incidence or prevalence of Radix Entomolaris in the first molar is about 12%, and in the second molar far less, about 1 or more than 1% in mandibular second molars. But we don't have to forget that we have predilection or incidence in some ethnic groups and populations. So we need to know when to expect the presence of such anatomical variation in some ethnic groups and populations. So if we look to the prevalence in the literature, we have studies from UK, from Netherlands, Germany, and it showed that it has very low incidence or prevalence in European descendants, maximum 3.5%. However, when we go to the rest of literature, we can find that there is a very high incidence in the Indian American population and Eskimos, reaching 40%, less in Asians and Euro-Asians, 4%, and 3% in African, Middle Eastern, and Caucasians. So now we can know which population is mostly will have or might have such an extra distolingual root in their mandibular molars. However, all these studies that I was talking about was based on detection of the Radix Entomolaris using clinical and intraoral radiography. CBCT studies, and you can find all these studies in the book that I was just talking about, the root canal anatomy of human permanent teeth. Regarding CBCT studies or detection, few recent studies are available. However, they are mostly case reports with a low level of evidence, but it showed that we have 22% of incidence of Radix Entomolaris in Chinese, Taiwanese, and Korean population in the first molar, and less than 7% in European. The only population that was examined by CBCT to detect Radix Entomolaris was the French population. Another interesting feature in the incidence of Radix Entomolaris is the bilateral occurrence. So I might expect that I have a patient with one tooth having a Radix Entomolaris. I will look to the other side and I might find a bilateral occurrence in the same patient. A lot of case reports along the years, 2009 up to 2019, and maybe in 2020, I didn't check yesterday, but there are studies or case reports and case series reporting the bilateral incidence of this extra distolingual root in mandibular molars. Now we will move forward in a clinical approach, and I have to highlight that when we are talking about the management protocol of any anatomical feature, it will start with the diagnosis. So how to diagnose the presence of Radix Entomolaris? As we know, the official and the usual and the way we should do it is the intraoral periapical radiography. However, the intraoral periapical radiography have a lot of limitations, mainly superimposition. Superimposition can be partly resolved by beam angulation, and beam angulation here means to shift the beam or shift the cone of the X-ray to be able to see hidden or superimposed structures. The other limitation of intraoral periapical radiography is the inability of the operator to detect buccolingual curvatures. I mean, the curvature that happen in the third dimension. And this is can be solved by the CBCT. However, there are a lot of question marks regarding the use of CBCT as a routine preoperative evaluation method. I will go through the beam angulation rules and the CBCT. Regarding the beam angulation, before we know how to direct our beam from the mesial side, from the distal side, how to shift my cone during periapical radiography, I should first know what are the radiographic types of Radix Entomolaris. In 2009, there is an important study reported the radiographic types of Radix Entomolaris, and we can see here the type 1 is visible without any cone shift. This is type 1. Type 2 is partly visible Radix Entomolaris, and type 3 is completely hidden behind the distobuccal root. Now, for each type, I should know how to detect it, and then we will summarize how to detect it easily. Type 1 Radix Entomolaris requires no beam angulation. A parallel radiograph, a parallel technique will reveal the Radix Entomolaris as you see in these two images. Type 2, which is partly visible, requires at least 15 mesial angulation. I can say 15 horizontal mesial shift and 25. We can put a range of 15 to 25 mesial shift in order to detect the type 2 Radix Entomolaris. The type 3, which is very difficult in detection and can be superimposed in many directions, only the 25 degrees mesial angulation or mesial shift can reveal the presence of this extra distolingual root. To sum it up, in order to detect accurately the Radix Entomolaris on intraoral periapical radiography, we need two preoperative images. One in a parallel direction with no horizontal angulation, no mesial or distal shift, and the other with at least 25% mesial angulation. These two are needed in order to detect if there is a hidden Radix Entomolaris in mandibular molars, which is more frequent in mandibular first molar and less frequent in mandibular second molars. Regarding the cone beam computed tomography as a diagnostic tool, we have to ask ourselves a question, an important question, which is when to ask for a CBCT for evaluation of anatomy. Is it regularly we use it? To answer this question, we should go back to the position statements of the European Society of Endodontology and the joint statement of the American Association of Endodontics and the oral maxillofacial radiologist. CBCT should not be used as a preoperative evaluation tool in a routine way, should not be used routinely for preoperative evaluation of any endodontic case. However, we can say that we need to set an indication for the use of CBCT in some cases, like the cases we are talking about of extradistolingual root called Radix Entomolaris. This case is presented to the clinic referred from a colleague with a broken file in the distal root. Careful evaluation with a proper radiography and proper radiographic technique revealed that I have two broken files. It's okay, we have two broken files. However, the broken files are not aligned with the distal root, which is highlighted in red. It's more to be deviated from the central path of this root. And I have found that there is a shadow behind this root. And we can classify this case as type 2 Radix Entomolaris. So when I have a treatment mishap I should evaluate the condition with the CBCT, because Radix Entomolaris are curved in the buccolingual dimension, and when I have a broken file, I will use my ultrasonic tips. If I didn't recognize the curvature, the level of curvature, and the length of the root canal and the length of the fragment, I might perforate or make a ledge at the elbow of this part. So CBCT helped me in this case to evaluate the previous treatment mishap and secured me against doing a lot of mishaps again. And we have to know that the Radix Entomolaris is cute and is straight and looks easy on a two-dimensional radiography. However, when we look on a CBCT, we have curvature in the buccolingual plane. We might have double curvature even. We have a curvature with short radius, abrupt radius, which may lead to ledging or perforation in this area. And we have sharp angles also. So if I didn't evaluate this condition and only this condition, I might do many mishaps and I will not be able to save that tooth. CBCT helped me in this case to successfully remove the file without inducing further damage to the radicular dentine. So as you see, we were successfully managing those broken files, and now the case is clear, and now we can go for our endodontic treatment in a usual way. To summarize, with a two-dimensional radiography, I need two preoperative radiographs in order to detect possibility of Radix Entomolaris in a mandibular first molar or second molar, and CBCT will be needed if the treatment previously done with a mishap, so that to evaluate it. Now I'm going to discuss a case of a mandibular second molar with Radix Entomolaris type 3, which is the most difficult part. The Radix Entomolaris is completely hidden behind the distobuccal root. There was a previous treatment attempt from the colleague initiated the treatment, and it resulted in symptomatic apical periodontitis. If you're taking notes, you should take a note of this rule, because other than the rules we talk about in radiography and CBCT, we need to inspect the pulpal floor in order to confirm the presence of a Radix Entomolaris. So in a usual molar, when we measure or look into the inter-orifice distance between the mesiobuccal and distobuccal root canals, which is named B here on the slide, and the distance or inter-orifice distance between the distobuccal and distolingual canal, we will find that the distance, the inter-orifice distance A, is less than or equal B in most cases. However, when we are dealing with a tooth with Radix Entomolaris, I will find that the inter-orifice distance between the distal root components is larger than the inter-orifice distance between the mesial root components. This is a very important rule, and you should notice this. It is called the inter-orifice distance. It's kind of, you find that access cavity preparation is not rectangular, it's more trapezoid with a larger dimension towards the distal side. When we detect, we should use the suitable files, we should use a suitable technique in order to shape the root canals. So in this case, I use the Wave 1 Gold reciprocating instruments. And the sequence of instrumentation was to make a patency to a super loose size 10K, and then we go to a pre-flare with the Wave 1 Gold primary file in the coronal third of the root canal only, without going down. Then we create a full glide path in all canals using a glide path file, and in this case, I used the gold glider from the Wave 1 Gold. Then I went full length with the Wave 1 Gold small, Wave 1 Gold primary in all root canals except the distobuccal, which was very wide canal, so I decided to go with the medium. The size of all root canals finished at 25 3507, and the distal buccal canal only finished to 3505. Then, due to the presence of symptomatic apical periodontitis, my favorite intracanal medication is calcium hydroxide with iodoform. It helped me in a lot of cases. So I applied the intracanal medication to the full working length. However, there is a very, very bad disadvantage in this type of medication, which is oily or oil-based, so it sticks to the root canals, and it will be difficult in the second visit to remove completely from the root canal. And we should highlight here that we should remove all remnants of intracanal medication before proceeding to the obturation phase. In order to remove completely any remnants of intracanal medication or filling materials from the root canal, the maximum benefit can be established by using two types of activation methods, the finisher files and the passive ultrasonic irrigation. This video, I will show you how to use simultaneously and to shift between the use of finisher file. Here I use the AF Max blue file in order to loosen the debris. I use it in a setting of the XP endo finisher in the Econnect S motor, 1000 RPM minimal torque. And then we use side bended needles for safety and use a lot of irrigant sodium hypochlorite in order to loosen much more debris. Then I will apply the passive ultrasonic irrigation using the Ultra X. So we alternatively use the Max finisher or XP endo finisher. Then we flush the root canal to lose more debris, and I use the Ultra X or any passive ultrasonic irrigation alternatively in order to loosen all the debris until I get clear canals, as you see in this video. Alternatively, finishing files, then ultrasonic irrigation, finishing files, then ultrasonic irrigation. Then we flush the pulp chamber, and under magnification, we examine the clearness of the root canals down to the apex. Now we are ready to move to the obturation phase of this molar. And as a standard in root canal obturation, three-dimensional obturation, I use the continuous wave of compaction. So we down-packed the mesiolingual canal, mesiobuccal canal, the Radix Entomolaris, and the distobuccal canal using down-packing device. This is followed by backfilling the root canals using a backfilling device in a continuous wave of compaction technique. And for radiographic confirmation, we can see that with a parallel straight preoperative radiograph, we couldn't see that there is an extra distolingual root with a high vertical and less than 30 mesial projection. We couldn't clearly see the Radix Entomolaris. However, with larger and more mesial angulation, we can see clearly that we managed and obturated the anatomy successfully. Finally, I want to give a take-home message to all the attendees to summarize what we have encountered in this webinar. I can say that the prevalence of Radix Entomolaris in the first molar is about 12% with the possibility of bilateral presentation. Caucasian have less incidence of Radix Entomolaris than Asian population. At least 25 degrees mesial horizontal shift is needed to detect Radix Entomolaris on intraoral preapical radiography. And do not forget that CBCT is used only for evaluation of complex case and not as a routine preoperative imaging tool. Finally, Radix Entomolaris are usually curved in the buccolingual plane with very short radii and sharp angles. So you should take care in order to induce further damage to the case. And I hope that we summarized this anatomical feature with incidence and management, and we are ready now for the questions, and thank you. I have received some questions here, and let me check. So the first question was, can we detect without the X-ray? We can detect if you missed the anatomical feature on the periapical radiography, then you can detect it clinically, as we said. And let me get back to the presentation to remind you of the most important clinical rule of inspection of the pulpal floor. We need, sorry. For the one who asked about the detection, yes, we can detect it clinically by evaluation of the interorifice distance. With the Radix Entomolaris, I have an interorifice distance between the distobuccal and distolingual orifices larger than the interorifice distance between the mesiobuccal and the distobuccal root canals. What if I am the one who accessed the case? It might fool me. Yes, if you access, you should follow the inspection of the pulpal floor rule, the interorifice distance. This is very important. If you didn't see it on the X-ray, then you should inspect carefully the interorifice distance between the distal canals. Someone is asking about the microscope. This case has been done. I'm using two microscopes in different practices. The one I was imaging in this case was a Labomet. How many days left calcium hydroxide in the canal? Usually at least 7 days, 7 to 10 days, and we can leave it up to 28 days if there are, the symptoms persist. So I can leave it. If symptoms persist more than 28 days, I should refresh the calcium hydroxide, remove it, irrigate, accentuate my preparation, and then reapply it again. Concerning what about Radix paramolaris? Radix paramolaris is of high incidence in mandibular second molars and with a very, very low incidence. I think it's 0.5%. And we should know that the Radix paramolaris is present and extra to the usual canal. So I have to have two mesial canals, and the third is the paramolaris, and then distobuccal and distolingual or distal canal. So in order to know that there is a Radix paramolaris in mandibular second molar, I should know that I should have 3 canals mesially. Another question about why didn't you use water-based calcium hydroxide intracanal medicament? It's an oil-based. I should state that this is a personal preference. I used the water-based calcium hydroxide, like the meta paste, the white one, not the yellow one, but it didn't give me the antiseptic active action that I get with the Metapex. So I prefer with my patient the antiseptic activity of the Metapex. But as we discussed in the presentation, it was very difficult to remove in all cases. But as long you have the 2 methods for activation, the finisher files and the passive ultrasonic irrigation, you will be able to remove it completely without any difficulty. It might take some time, but it will be completely removed from the root canal system. Is there any clinical disadvantages for intracanal medication material beyond the apex? You should know that we do not intend to extrude any material beyond the apex. We should limit all the root canal filling materials, whether gutta-perca, sealers, or intracanal medication within the root canal space. However, sometimes if you put calcium hydroxide or intracanal medication without apical control or in wide apices, you might get an overfilling of this material. With calcium hydroxide, it will eventually resorb, and I have some cases that I extruded a little the calcium hydroxide. I'm not talking about gross extrusion. However, minute extrusion, it will dissolve by time. However, please do not. In order to limit your intracanal medication in the root canal space, you need to do an important thing. Take the syringe of the intracanal medication, adjust the stopper on the needle tip 2 millimeters short of the working length. Then insert the syringe or the needle tip into the root canal till the stopper, and then for one push of the plunger, do it at the exact length determined on the stopper, and then backfill in an outward motion. This will minimize to a great extent the overfilling of the root canal intracanal medication. What about the calcium hydroxide powder mixed with saline? Calcium hydroxide mixed with saline was used for direct pulp capping previously. Now we are, and this is a setting type of calcium hydroxide. Now we are using non-setting calcium hydroxide because it will be a great problem if the calcium hydroxide sets in the canal. So the type of calcium hydroxide, irrespective of the presence of iodoform or not, is non-setting calcium hydroxide. It's a pre-mixed syringe applied and removed as we discussed in the presentation. If your canal is dry, you should finish it in a single visit. Yes, if the canal was dry, in this case, it was having some exudate in the apical part, and there was severe tenderness to biting from the referral. So I decided to make it on a 2-session protocol. However, I think if there was no any exudate or severe symptoms, I can finish the case in a single visit, yes. What if the metapex which we use goes beyond the apex? I already answered that question. Try not to extrude it a lot, and if there is a small amount, it will eventually resorb. I don't know when will it resorb completely, but the macrophage will eat it eventually. What is the action and also mechanism of action of calcium hydroxide with iodoform? Calcium hydroxide with iodoform are two parts, the calcium hydroxide and the iodoform. Iodoform is an antiseptic. It cleans the canal, antiseptic action. The calcium hydroxide dissociates into calcium ions and hydroxyl ions. We need the hydroxyl ions to disinfect the dentin. It's alkaline, and it is responsible for moving the medium inside the root canals from acidic in the presence of inflammation or infection into an alkaline medium. The alkaline medium is antibacterial and it neutralizes bacterial byproducts. So I need calcium hydroxide to release the hydroxyl groups, and I need the iodoform to do the antiseptic job of the medication. When the other question is when we need an intracanal medication in the presence of apical periodontitis, persistent apical periodontitis. If I cannot dry the canal, if there is some sort of bleeding, I can put the intracanal medication and assess the case and re-see the patient in a second visit. What about Radix Entomolaris in upper molars? Radix Entomolaris is a supernumerary root in mandibular permanent molars only. There is no Radix Entomolaris in maxillary molars. No Radix Entomolaris in upper arch. Thanks, doctor, for your praise about the presentation. The next question is 35 taper 6 is not considered large. Why didn't go to 25? When we use any size in during our shaping, I do not standardize my sizes. You can see that I used in 3 canals size 25 primary file from the wave 1 gold, and the rest, the distobuccal canal was very large. There is something important. We are using anatomically guided shaping. So according to the anatomy and the width of the root canal, the curvature, and sometimes the obturation technique, I should evaluate the canal. If my file, and I will go back to the slide of if you are seeing the presentation now, if I go to this side, when I use this side in the distobuccal canal, the red one, it's called the Wave 1 Gold primary, just one stroke and it reached the full working length. And when I get it out, there was no debris on the flutes, so it didn't clean, it didn't shape. So when you find that on your instrument, you should go to a larger size. So according to the anatomy, I choose my final apical size. And also according to the preoperative condition, when I have pulp necrosis with apical periodontitis, I need to clean more, I need to enlarge the apex more than vital cases, for example. So it's a multifactorial condition, but in this case, the red file, the 2507 Wave 1 Gold primary, didn't shape and didn't clean. So I have to go for a larger instrument. Let me see the rest of the questions. Besides the diagnosis, what make different from other cases in terms of glide path, shaping, and obturation? Regarding the usual canals, the mesiobuccal, the mesiolingual, the distobuccal, there was no any change regarding the protocol, the usual protocol. Just we follow the usual protocol in glide path and shaping. However, we should be cautious in managing the distolingual route, because according to Carlson and Alexanderson, the classification of the curvatures, we might have very severe curvature in the middle part, and we might have a class of Radix Entomolaris according to their classification in literature with a double curvature in the buccolingual dimension. So I should be cautious during the patency and during the glide path preparation in the distolingual route. But the other routes, no change in the protocol, just follow the usual protocol that you are following in any usual case. Why we don't use just calcium hydroxide without iodoform? It's less sticky. I already answered that. It's a personal preference. It gave me a lot of good results in my patients. It's difficult to remove, but we mentioned in the presentation how to remove by alternative use of XP endofinisher or AF Max blue files, alternatively with passive ultrasonic irrigation, like I used the Ultra X irrigator here. Another question is any distolingual canal considered radix? No, we cannot consider any distolingual canal as a radix entomolaris. I will go back to the rule of pulpal floor inspection. And if you are seeing my presentation, I hope now this is the rule. On the left side of the presentation, this a usual distobuccal and distolingual canal. The distance between them will be equal or less than the interorifice distance mesially. However, with the distolingual canal far beyond lingually, the distance A is larger than distance B, then this most probably be a radix entomolaris with a trapezoid shaped axis cavity with a larger dimension towards the distal side of the pulp chamber. What happened if calcium hydroxide came out of the canal? We already answered that question before, and I will say one thing, because a lot of dentists in the previous day was questioning about the presentation or the live webinar that is deleted after the online. I gave everybody here the permission to use it for a week, so everybody can use it and see the video, take all the info for a week. After a week, it will be deleted. What the advantage of calcium hydroxide with iodoform? I said the antiseptic action of iodoform is beneficial in my cases. I tried both and I get better results, especially in pulp necrosis with apical periodontitis. How do you irrigate the apical area of in a big curvature? Does Ultra X have a curved tip? The Ultra X 2002 tip is very nice regarding the size, and it can be pre-curved. This is regarding the activation, but what is more important to consider is the delivery of the irrigation to the apical part in a double curved route. So we should use at least at least a maximum of 30 gauge needle, side vented needles, of course, for safety. And there are another types of needles that have been available recently, like the Trunatomy needles from Dent Supply. It's made of polymer like plastic, and it can bend according to the curvature of the root canal and reach almost 2 to 3 millimeter from the working length as you go down with your shaping files. How do you irrigate the apical area? Yes, does the Ultra X. Okay, thank you very much, doctor. Thank you for watching. Can you please repeat the removal protocol of the dressing? Okay, I will now play the video again for removal of the canal medication, and in order to describe it for you, we use alternatively the finishing files like the AF Max Blue or XP Endo Finisher. It is rotated in a clockwise direction at high speed, 1000 RPM, and if your motor can accommodate a higher speed like 300 RPM, then we can use it as long as it's not touching the root canal walls. I will reduce the volume. Then we irrigate to flush the loosened debris of the intracanal medication, and then we irrigate and apply our ultrasonic device in order to loosen more debris, and so on. I go multiple rounds of dislodgement and activation until the root canal is clear. Can you again how to detect clinically Entomolaris? Okay, and I repeat again that the presentation, I give the permission that the presentation will be available on the page for 1 week for any people, any doctor he want to see it again and see all the info and record some notes. It's okay, nothing wrong with dealing, because this info already present in literature. It's not the clinical cases. Okay, this is the demonstration. However, the rules are present in literature. We just summarize the topic. Clinically, I will get back to the clinical detection now of the Radix Entomolaris. Again, for the doctor who asked about clinically. Again, in a usual molar, I have the distance between the mesial canals. It's called inter-orifice distance mesially, equal or more than the inter-orifice distance distally. However, in a case with the Radix Entomolaris, the inter-orifice distance distally is longer and of larger length than the inter-orifice distance mesially. This is an important for clinical inspection of the Radix Entomolaris. How to irrigate the curvature? We said that side-vented needles, small gauge. Sometimes I use the 30 gauge Fanta needles with side vents. Many other cases I use the Trunatomy needles because it is flexible, and 3004 in taper. From Dent Supply, it is a Trunatomy needle, and from PD, Produit Dentaire, it is called the Airiflex. It's very nice with 2 side vents laterally. Is it a rule that there is a curve in the Radix Entomolaris? Most commonly, as reported in literature, and you can get back to the book that I told you and a lot of literature, that most commonly the Radix Entomolaris is curved in the buccolingual dimension with incidence of sharp curvatures with a small radius, and sometimes in type 3, according to Carlson and Alexanderson classification, we have double curved Radix Entomolaris. It's a very difficult route to manage in the presence of a double curvature. Can you please elaborate on your irrigation protocol? Irrigation protocol, just the usual protocol. I use sodium hypochlorite throughout the instrumentation, and then prior to obturation, I remove the excess of sodium hypochlorite. Then I flush with EDTA solution, and then I make a final flush with saline in order to make the substrate of dentine ready to receive the obturating materials. So it's a sodium hypochlorite 5.25% throughout instrumentation. Then I will remove sodium hypochlorite, and I will flush all the canal with 17% EDTA solution, and then finally a saline flush. I can repeat this irrigation protocol again with an activation method in order to remove the smear layer, both the organic and inorganic part, and then finally a saline flush prior to introduction of the obturating material. Another question, can you please elaborate? Metapex or Metapay twist? I prefer Metapex. This is a personal preference. I do not say that it's an evidence-based, it's a clinical preference. You can say it's my clinical preference, but you can use calcium hydroxide from any brand and with any combination, as long as it's non-setting, because setting calcium hydroxide is very problematic during removal. Especially iodine makes severe pain after applied. If you apply it to the full working lens without extrusion, it will not make pain. Actually, in my personal experience, and I repeat, in my personal experience, I experienced much pain with plain calcium hydroxide, the Metapaste, not the Metapex. So I shifted to the Metapex, and it was very nice. And we should make a statement here that the post-operative pain after the visit is not considered as a complication as long as you do not extrude too much material beyond the apex. What is the process for using Metapex to turn some cases to hot cases to cold cases? It's mainly depending upon the release of the hydroxide, the dissociation of the calcium hydroxide into calcium ions and hydroxyl groups, and the active group here is the hydroxyl ions. It, as you say here in your question, it can convert from a hot case to a cold case due to alkalinity, change the medium of the root canal. Does Radix Entomolaris usually have smaller dimension preoperatively, and what is the large file we can reach in this route? As I said before, I cannot make a rule for the Radix Entomolaris to follow. I cannot say with Radix Entomolaris finish the preparation at 2504, 2506. No, we should use an anatomically guided rule. Meaning when I properly assess the case during preoperative evaluation, during patency and glide path, and the patency file is important because it can take an impression of the curve. So I cannot make a large diameter preparation in a double curved route. I should limit the shaping size because I might perforate the route. So I cannot make a rule. It's based, I can say it in many times, the shaping size is evaluated based on case by case basis. So I cannot make a rule. There is no largest side. Sometimes we can find a Radix Entomolaris with a straight configuration. So in this way, you can enlarge as necessary. Then we should move forward with questions. Regarding the use of reciprocating files or reciprocating systems, according to literature and evidence and also clinical practice, we find the reciprocating motions are very beneficial. I even can use a reciprocation motion or reciprocating single files or systems because they are not necessarily single file. I can use the reciprocating systems even without prior manual glide path. So it is very efficient and very safe regarding the shaping of severely curved and double curved canal. And we can recall the paper in 2018 by Professor Gambarini for classification of kinematics. And we found that even with a large instrument using the reciprocating or combined motion and combined motion like the ATC and the eConnect S and the optimum glide path or optimum OTR motion, we can use these motions safely to shape the canal and extending the time to fracture of the file. So it is safer to use reciprocating motion or combined motion to shape curvature, severe curvature, small radii, and double curvature. So it's a recommendation nowadays. What's your opinion on bioceramics and single cone obturation? Well, I cannot make a statement about single cone obturation with bioceramics. Bioceramics are very, very nice materials, but we do not have sufficient evidence on the single cone with the bioceramic. Of course, the properties of the bioceramic material is very nice. However, I cannot depend on it in all cases. So sometimes we can use it, and many other times we should go for a three-dimensional obturation because it is more predictable to obturate the canal in 3 dimensions. So I prefer to use, in the majority of cases, the warm vertical compaction or the continuous wave compaction, and in some cases in which the size is perfectly adapting to the my shaping files and my cone. So in these small cases, I can use a single cone, but I do not depend it in my treatments much. Thank you for attending. Why you enlarge canal size and taper together? Not one of them, not to weaken the roots. As I said before, it's not a rule. In some roots, I can stop in 25 or 6. Other roots, I should go more. It depends on a lot of factors: the preoperative condition of the tooth, the thickness of the radicular dentine, the obturation technique. A lot of factors govern the shaping size. So according my evaluation, according to interplay of these all factors, I decide my final size. It's not a rule. I used one size in 3 canals, and one canal I used a larger size. This is according to the condition of this single canal, which is a distal-buccal canal here. Can the Radix Entomolaris have more than one canal? No. Radix Entomolaris is a single root with a single canal. In the paper that I mentioned, Gu et al. In 2010, there are 3 parts. One of them is about the floor inspection. Other one is about the root canal system. So this paper in 2010 and 2011 reported that mostly mandibular first molar with Radix Entomolaris will have 2 mesial canals with separate configuration. However, this cannot be evaluated as a rule that we can follow, but the Radix Entomolaris is a single root with a single root canal, and we can say it and classify it according to Vertucci as type 1 Vertucci classification. What is the meaning of A plus B? No, A is not plus B. In this image, I compare a tooth without Radix Entomolaris on the left side and a tooth with Radix Entomolaris. A is equal to B in most cases, and sometimes A is less B in most cases. With a case having an extra distolingual root, the distance between the distal root components, which are distobuccal and distolingual, is larger than the distance between the mesiobuccal and mesiolingual canals. That's why A, as an inter-orifice distance distally, is larger than the inter-orifice distance mesially. Any other method for removal of metapex? According to literature, you can use finisher files, XP Endo Finisher, AF Max Blue, AF Max alone. You can use passive ultrasonic irrigation. You can use sonic irrigation, but the best method to ensure that most of the material is removed is to combine the mechanical activation by XP Finisher file and the passive ultrasonic irrigation. Any other methods? Just answer. What if the intracanal medication didn't reach the full working length? Already, I can show you in this case that the intracanal medication didn't reach the working length in the radix, probably due to the curvature, the buccolingual curvature. So it's not a problem. Most of the canal was soaked in the intracanal medication, and I was hoping and I was lucky that the groups dissociated from the calcium hydroxide, the hydroxyl groups, did the medium modification to an alkaline medium, and the patient came after 1 week completely symptom-free. If we inject the canal of medication cannot control if we can go outside the apex, I just answered the question, and you can get back to the presentation. It will be available for 1 week on the ET medical Facebook page. Which one vertical compaction equipment is the best about? What about EQV? Well, I cannot say the best because there are a lot of equipments. I've used the fast pack and fast fill. I used the Data Smart from Dentsply. I used the Diadu from Diadent. It's the most important is how to get a proper learning curve with your device. The ergonomics is important. So when you are using a backfilling device with a motor like the fast fill or the Data Smart backfilling device, it's better tactile feedback during backfilling than the usual gun. But I cannot say that this device is better than that device. It depends on the learning curve. You get your device according to a lot of factors, for example, the economic or financial aspects of your selection. But the most important is you get to increase your learning curve with the instrument and to follow the right protocol for using that device. EQV is very nice. I used it before, but not much. What about carrier-based fillings with the bioceramic sealer? Carrier-based obturation are very nice, easy, but there is a question mark about the use of heat with bioceramic or the presence of heat with a bioceramic material. A lot of techniques seems to overcome the problem of the bioceramic sealer, and a lot of bioceramic sealer brands like the Endosequence High Flow and the Avalanche sealer, it's called High Flow also. The High Flow sealers, the bioceramic sealers, can be used nowadays with heat, but there are a lot of question marks about the actual amount of heat at the tip of your downpacking device. So a lot of question marks, but carrier-based obturation is very beneficial, especially in a slim root, a narrow root canal, a double curved root like the Radix Entomolaris, as long as you know how to apply the carrier-based technique. What about, okay, how to know true and false talkback, how to select the master cone. I will answer it in a very, the talkback or the apical fit of your filling is important. So the most important part during gauging your shaping size apically is to use a small taper instrument and a flexible instrument. So we can get these two factors in a night-eye hand instrument, a night-eye hand instrument. So if you are finishing the preparation with a 2506 file, you take your night-eye hand instrument of size 25 corresponding with the shaping file, and you gauge your apical foramen. This is the most important part in gauging. If you find that the 2506 is not going down, so you select a master cone or a Gatopirca cone with a smaller taper, let's say 2504. That's how you make sure that you have a tuck back from the apex and not from the coronal part of the root canal. How many settings you prefer in this case, single or multiple? I was forced for a multi-session protocol in this treatment due to the presence of apical periodontitis. However, I prefer to finish my treatments in single visit as long as the patient is not exhausted and as long as the case permits a single visit protocol. Why not use a single cone with an add seal as long as no clinical problem after obturation? No, single cones, I do not use single cones with a resin sealer unless there is a perfect fit in the root canal, and that doesn't happen in every case. On the contrary, we have very small percentage of cases that your master cone is adapted apically and coronally. So I cannot depend on a resin sealer along the whole length of the canal. And resin sealer is not insoluble, it's of low solubility. And the solubility might be a problem, especially in cases where the coronal restoration will not be perfect. So I do not recommend the use of a single cone with a resin-based sealer. In which cases you usually use the Metapex? I use the Metapex if I cannot dry the canal, if there is an infection residual in the canal in the form of an odor, even after shaping and irrigating with sodium hypochlorite. If I have persistent discharge, if I have persistent apical periodontitis, if I have an exudate from the canal, bleeding, and sometimes if the case is extremely tender to biting. File system, in this case, I use the Wave 1 Gold reciprocating system. I depend on this system in more than 95% of my cases. The other systems that I use in other cases are the Pro Taper Gold. I use the High Flex in some cases. But to make a statement here, an endodontist practicing everyday endodontics cannot commit to a single file system. You cannot depend on only one system. You have to mix your systems. You have to have all the available options in your clinic in order to suit the anatomy. And we have to make another statement. Anatomy is of high degree of variability. So I cannot just standardize my file system and I'm asking the file to suit every and all the anatomical features in all the dentition that I'm treating. So it's not logic. So I should have in my clinic a lot of systems that can suit everyday anatomy that I'm meeting in my clinic. What we do in the X-ray if we have superimposed teeth that needs a root canal. How can I detect the canals as it is superimposed? So if I have let me ask if I get this question right from Dr. Muhammad Abdel Khalid. Sometimes we have premolars in an orthodontic patient with improper alignment. So sometimes I have two teeth, premolar teeth superimposed. If I want to detect the anatomy conservatively using an intraoral preapical radiography, I should make 3 preoperative X-ray: a straight parallel X-ray, then a horizontal mesially shifted X-ray, and a distally shifted X-ray. And I evaluate. If I'm suspecting a complex anatomy in a tooth and I am afraid that I'm not going to manage there properly, I can take a CBCT to confirm the presence of an extra anatomy like the molarized premolars or the presence of an extra rutinomandibular tooth. However, we do not use this regularly or routinely in our clinic. The second part of the question, to answer the question completely, is to evaluate clinically the anatomy of the pulp chamber. And not only the pulp chamber, I should evaluate also the anatomy of the cervical part of the tooth. I'm not receiving more questions. So I hope we fulfilled all the raised points, and I hope I was brief and to the point. I hope it was beneficial to all the attendees. Thank you for inviting me, Etif, to join a lot of doctors worldwide. That is a great and extremely large exposure. And I repeat, I authorize the use of my presentation on 80th Medical Facebook page, and only on this page, for all the attendees to see it for a week. And please see it during this week, because it will be deleted after 1 week. And I will be glad to receive any questions on my personal Facebook page, on my professional page, and even on my Instagram anytime. Might be a delay in response, but I will eventually respond. Thank you so much, and I was very happy to be with you today. Thank you so much.